Yeah, and you can see on the chat, people are responding. Great. So today, last week, we talked about the budget and the budget situation. Today, we had an interesting meeting because what we keep trying to do here is constantly refine our communication. Like Tuesday, there'll be a CBSN interview with me, which hopefully goes well. It's with Paula Eben, who's great. We just submitted an op-ed on the situation. We'll see if the Globe is okay with it or not. But we are going to go further. And obviously, we're communicating with State House News, which is important. But all of you can communicate, and we'll have a phone to action up, I expect, within the next day, because maybe tomorrow. We've been refining because it's hard to message this. And so today I changed. I'm going to get more specific about the budget. I'm going to walk through the COVID stuff as we normally do, but I am going to walk through it more specifically. And if you're, I'm especially interested in your reactions as a family member or a person with a disability, because we're trying to refine it. And again, trying to refine it so we can communicate this double bind we're in, where we have services, right, that are being provided that aren't getting to everybody. And here's the irony of it, right? Because of the infection control guidelines, fewer people are served. And yet, on the other hand, at least as much money is needed. And that's what I'm going to try to explain in a coherent way. And we're going to see if it, based on your dialogue today, if that works. The other thing I'm going to do today before we're over is tell you what the tentative series looks like looking forward with the not only Leo Live, but also the monthly government affairs session that'll happen with Maura Sullivan and Ellen Taverna. That'll be federal government affairs once a month on the third week. And I'll be on the fourth week also doing it, but letting them have most of the good, well, hopefully good news, most of the new news on week 3. And then I'll follow up with either highlights. Week 1 is going to be about policy as a role and policy issues. So that we'll get to do together. And week 3, we're going to have Kerry Mahoney with us talking really like a clinic and resources and the kinds of things she's been doing throughout the COVID crisis on Tuesdays. And on Tuesdays, on second week, thinking about the whole series of issues around personal choice, social inclusion, self-determination, that theme. So, and hopefully on week 1, we'll talk about some of the policy barriers that those services experience. But, week 1, we might also on policy talk about innovation technology that's happening. Not only are we trying to do that at the ARC, but we're working in collaboration with ADDP and the state's Department of Developmental Services to advance some things there. So stay tuned and let's start now that I've delayed us a bit. So it's bad. We all know that. You don't have to listen to me to know it's bad. If you remember last week when I had a couple of weeks off, I said we had an average of 4,000 a week new infections. A few weeks before that, it was only 2,000 growth. It got to 2,700. So we are really, it's really bad. I mean, 5,276. And I didn't have the time because I was refining some other things with this and I have a few other things to do. But I wanted to look and compare it to the high points during the first surge. You will see a chart in a few slides, 2 different charts on the US curve. So basically 5,276 people. And now finally we're seeing deaths rise. And I don't know if you recall, I mentioned despite the slow rise, and I wondered if it was a lot of young people getting the COVID virus initially, but we've gone from 99 or so, 95 or so dying a week to 137. So that's what's happening in terms of the larger population, which we'll come back to when we take a look at a couple of US curves. But also this week, and we just had an interaction with our friends at Disability Trust Center, I was working on something. In fact, I was working on something related to both the op-ed and the TV thing. And I was trying to think about how can I really emphasize how serious this is. And I used one of the old charts during the surge. This was before I got an email or Maura and I got an email from Rick Glassman and Hillary Dunn-Stanitz, and the email from Rick said, hey, did you see it yet? Wednesday, as I've shared with you, every Wednesday, a report comes out. That's what's happening in our world and at the state institutions and elsewhere in terms of state facilities. And again, it's not significant yet, but to see the jump from 19 to 34, I concurred that that's, okay, time for some proactive stuff, maybe time to look at what agencies had higher rates of the pandemic during the surge, and maybe some visiting by service coordinators, maybe by an area director, both virtually and maybe out, outside the house, but getting involved with the agencies where the numbers were higher. I think extra reinforcement of infection control is going to be so important. And yes, I'm sure many agencies, most agencies are doing an awesome job in this, but to reinforce it, because and I know human nature, we really need to be all hands on deck and more together than we were in the first surge, right? Having the state folks connected to the provider folks during this, as well as what they did with the family support centers during the surge. Some reports we had of great collaboration, but we really need that right now. So 34 cases out of 7,762 people served. No, it's not a crisis yet by any means. But the other thing, it's interesting if you do these percentages, the state congregate homes, which have built in, by the way, 3 staffing levels, the provider homes, as a rule, do not. That's not to say there aren't some homes that are rolling nursing homes or whatever that might have 3 shifts, but those homes actually have 3 shifts. They usually have dedicated nurses. The providers have to figure that out with budgets that vary greatly from the state operated, which serve about 1,060 people. So when you run the percentages of cases, even though there's less than 5, which we don't know what that means, state operated homes, those cases are not statistically significantly different, the number of cases. The other thing I should tell you is that Rentham, where the percentage was smaller than at Hogan Institution, as you know, larger settings, regardless of what the largest settings are, the virus ran rampant during the surge, right? At the Hogan Regional Center, not only were tons of staff infected, but 50% of the people living at Hogan were infected. Right now, in the last report, there was 0 infected. We don't know about second exposures and all that. We do hear of people getting the virus again. But at Rentham, there's several cases already, and they have less than 300 people there. So that percentage is, if I was there or overseeing that, I'd be concerned about infection control. And I am concerned about it. I'm not there, but so I think. So the next 2 slides, what's interesting, I had used the first slide with a presentation, not a presentation, a welcome I did with my colleagues that do Widening the Circle and Pathways to Friendship. And I just, was doing an overview. And this first slide shows you the curve, okay? And I have your names and your pictures in front of this. Let me pull it down. If you see how the surge is not quite yet right where the old one was? See how it peaked? Looks like it peaked in August, right? And then you look further down and look at October, how it hasn't gone here, right? So this was a week and a half ago, right? And in New York Times. Now, here we go. This weekend, or I don't know if it was Fridays, Saturdays, whenever I worked on this, I worked on it Saturday. So if you take a look at this, look at that now. See?
Yeah.
So it's for real. It's happening. I think the average American, I mean, I don't know if people are looking at this, especially in the States where people are fighting masks and all of this stuff. I don't get it. But, look at that. That's there, the arrow, you see the arrow, and look at that, okay? That's just in a week. Okay, and here it is, the date, October 24th. Okay, so we're in it, and we know people with disabilities are at risk. I shared a really tough story there, and I'm not going to show you the picture. I could show you the picture, and I should show you the picture, but if anyone's heard my video blog last week, I talked about Michael Hickson, and he's a gentleman who had a family, who had brain injury, person with a disability, and African-American, by the way, in Texas. And his sister, by the way, happened to be an MD. So her sister's there. They're all like, it's August, I think, July or August, I'm trying to remember. And basically at some point they just decided to stop treating him. And the sister who had her tape on, which is allowed in Texas, a one-way approval tape. She said, "Are you telling me that his quality of life is because of his brain injury? That's why you're going to stop treatment?" And he said, "Correct." And he's taped. The doctor's on the tape. Um, of course, she being an MD, once she returned to Washington to her job, Washington D.C., you're not going to get any quotes out of her because I'm sure her folks have said, "Hey, cool it." Um, but to their credit, ADAPT and other groups in Texas have been demonstrating about this. And it's just a great example of how it also heightens that anxiety. There's not only anxiety of what people are doing, whether they're in a group home or whether they're in a situation with family or whatever, that the help they need. Some people are less assertive than others. Just getting the right help, right, on step one is such an important issue. And then the whole issue of making sure healthcare equity is there for folks we care about. Okay, so it's something we have to keep on the top of our minds. So these are the issues. Still the same issues we've talked about. Still a little different words, a few different words. I added equitable assistance for new families at home. So equity on more than one level, not just about disability, about race, about economics, working families, poor individuals, people out there independently who have a disability, who aren't getting, who don't have resources maybe, right? We know what the economic situation is for them. So just our having these issues on the top of our mind. And, we know if you look at the bottom, nationally, we know the Senate's not willing to include, well, state leaders, Senate leaders. I won't talk about the average Senate Republican. I'm just talking about the Senate leadership. They're not willing to include state municipal aid in the stimulus. And we're arguing for a very slim stimulus that honestly was just about giving checks to people, which is important, but is a little, doesn't get the whole job done, right? And it's sort of a way during an election to make people happy. I hate to say it like that, but because it is something that should be done, people that are out of work, people that are in need, and we know that the food banks and they're totally over utilized, right? So it's something we all personally also have to take some responsibility in. So here it is. We're going to take this apart even more, okay? And I'm not going to race through it. And after each one or two slides, I'm going to ask you guys to feel free to ask me questions. Because remember, the irony here is if you're a family member who doesn't have a loved one in a residential program, or you're a person with a disability who's living in an apartment and you're not getting enough supports at home, the idea of some of these investments may not be, as appealing, but more importantly, they may not make sense to you. And that's what I don't care about the appealing part. I want to make sure it makes sense. Okay, so basically, here's what we have. We have, obviously, the first slide is going to focus on LTSS, which is long-term services and supports. And I can't believe I didn't spell it out. So we'll have to make sure before we send this out, we spell it out. But individuals and families without residential. Okay, so day employment services are available through DDS, Mass Health, or MRC, right? That can be sometimes the biggest support a person either living independently or at home with family receives. I am not going to focus on the MRC funding much because that's a lot of their money for employment's federally based and channeled. I am going to focus on DDS and Mass Health Day and employment. And that really means the employment side is really Department of Developmental Services. Mass Health is our Medicaid agency. And then the other piece, and there's more to this than just PCA and AFC, Personal Care Attendant Program, the Adult Family or Foster Care Program through Mass Health. Obviously, people take advantage of durable medical, people take advantage of nursing. There's certain, services for autism, communication, right, and related services that are available through Mass Health, through insurance, both Medicaid and private, ABAs and such. There's adult day health for a lot of our senior citizens that need that service, and as well as older persons with disabilities. So there are other services, but I'm focusing in on the two core home supports and some of the issues we face. So slide number one, family support dollars were higher through June during the surge, not now. And we've asked for that an additional 8 million, and we'll see that later, which would mean relative to 2020, $15 million, okay? Why? Because Carrie in her meetings with family support centers and in our talks with you guys, whether on the webinars and elsewhere, that support through June was huge. Having it available, everything from food security to additional assistance at home and so on and so forth was essential. And it's even more essential when you look at bullet 2 here, personal care attendant funding. Remember that additional funding or additional hours were made available, right? But as of late May, early June, when I had Whitney Moyer on, it might have even been later than that, but I didn't want to lie. So I'm picking an earlier month in case it did grow a little bit later. The funding, the dollars of the program stayed stable. And I think from their point of view, that was good because it showed people weren't losing services. But to my point of view, it wasn't good, right? And the ARC's point of view, because it meant, where are all those additional hours to help people that aren't in school, right? All those additional hours to help people that were not in a daycare employment program. How come it didn't go up 10% at least, right? So that's the kind of stuff we look at, at the ARC as a team and volunteers as well, and not only staff. And we ask ourselves these questions. And this is the kind of stuff that, we haven't been able to get far on in the advocacy. It's been on the table, ongoing. And I think there's 3 factors to this. I think there's the double bind factor. If you're an individual or a family where you're not going to let anyone come into the home, I get that. But I call that the double bind factor because how do we help you, right? And at some point, if you can handle, a lot of people can handle their circumstances, don't get me wrong, but if it's overwhelming because of behavioral, medical, or other reasons, there's no way to help if there's no way to get assistance to the home. At some point, just giving people money doesn't really do the trick, right? Unless they don't have food or can't pay their rent or whatever. That's what the money helps with. Difficulty recruiting PCAs. I think people continue to have difficulty with that, though. I heard a great story from somebody about finally somebody who couldn't get even, more than 10 hours a week of non-related PCA help because of the school situation and remote and colleges. They were able to get some additional staff finally. So that's great, awesome. And then I do believe limited hours played a role in this because if in your vacation week, you're getting like 6 hours a week, I mean, a couple hours a day, even though you were at school or a day for 6 hours a day, that really isn't going to amount to much, and maybe you won't even get it filled because it's such a small additional window. And then for those in adult family or foster care, separate from a rate process that's going to happen this year, separate from potentially needing additional funds for PPE, they haven't gotten any help with any of that. We do believe people need stipends, and we'll talk about that again, especially where the housemates have lost their day services, which is at least 40% of the population. It could be even more. Okay, any questions about slide 1 before, or maybe we should go through all 3. Kerry, what do you think, Kerry? Maybe I'll go through.
Let's give people a time to think about a question on the family stuff. And if we don't have any, we can just move on.
Okay, yeah, great idea. And then Randy asked, do you know if there's COVID stats? Actually, so here's one. So I don't know if we're talking about saying there's not a breakdown. What I just gave you actually is about private providers. If you mean separately from private providers, I don't think so. But the link, let me see. I can show you guys the link. Why don't I show them the link, by the way, on that? Because let me just stop sharing for 2 seconds. Did that stop? Or did I do something stupid? Hello? Kerry? Oh, boy. I don't know what I did wrong.
Sorry, I had to unmute. Yeah, no, that stopped you.
Okay, I'm still there. I'm still there. Okay, I just got paranoid that I did something stupid. I'm going to share something else, you know, and I got to go to the slideshow, of course, to grab the link. And
So
that's that.
now for Kathleen, did you raise your hand for something?
Yes, actually. I'm a parent of he recently turned 22 in a CBDS program.
Mhm.
And we're starting to hear from the provider that bad things are going to happen in January, and literally that's all they'll say. From what I understand, due to the spacing requirements, they basically lose money every day as a result of meeting the requirements. The number of people who have there are some people who are eligible to come back who are still not yet comfortable coming back. And as this process sort of continues going forward, because it unfortunately doesn't look like things are going to improve to the point where they could consider increasing the number of people that they serve, I'm concerned about what's going to happen to his services, plus the overall viability of his provider.
So this is great. You're actually, because these are connected, I put that issue up there, right? The day and employment service, right?
Yeah.
And the CBDS. I'm going to be talking that in more depth, and you understand something because you've talked to them that is a lot harder. Like the average family would not understand, or average individual, if they haven't talked to someone about it. Okay, because so here, that provider that's serving now, right? They have to have more people in the classroom if it's a CBDS situation. That some actually don't allow people to go from one room to another because they take the guidance literally, okay, in terms of infection spread. So that means you may have 2 staff to 4 people, where you might have had 1 staff to 6 people and had a staff rotating among 2 or 3 class groups. So in addition to that, you have staff in case someone gets sick. You have the van situation. So basically, what we asked people, it's not about more money. We said, if you got paid the way you were getting paid before COVID started, would you be able to at least get through it? You might not, break even, you might lose some money, but could you be able to get through it? And from a number of agencies, from at least 22, I got the feedback, yes. And so that you'll see coming up. We'll be talking about a specific fix for that. Thank you for raising that, though. And we will talk, maybe I'll ask, they mentioned the additional staff, correct, to you?
Yes.
That provider. How about the vans? Are they transporting it all or no?
They actually are transporting, but again, it's, that's 2 person per van and a driver.
Yeah.
And no, they can't have a monitor, which is for us works out fine, but for a number of other of their clients, that may not be possible due to the needs of that person. They need extra support to be able to access transportation.
Right. No, so you're actually, hey, you're doing my presentation part of it. So I appreciate it. No, this is good. It's really helpful that you're sharing that experience, because that's what's really hard to sort of break through. So here's the chart. That's on that link that I have that you will get every week. Usually I keep that link in there. It will take you to this site. Page 1 is the institutional facilities. Okay, this is what it looks like. I haven't shown this in probably 2 months, so I'm glad the question was asked. So slide 1 is, you can see Chelsea Soldiers Home, Corrigan Mental Health Center. Now, what's interesting, if we looked at an old one of these, okay, they have current patients recovered, okay? Now, what's interesting is Hogan's accurate? Let's see, yeah. So this tells you, and I'm assuming this is accrued from the first surge, but I look at, like, so what I do a lot is I'll go to the archive. So if you Google Mass EOHHS, Mass EOHHS state congregate sites, if you Google that, you will always find the predecessor page to this, okay? And the predecessor page has the most current chart, right, which we're looking at October 20, because it's every Wednesday. And then if you look back, you'll see an archive. And I look at June 10th a lot once in a while, just to look back. And I look at what it was like, how bad it got in the system. And so if you look at, again, here's Rentham with 213 people. They have 6 people infected right now, okay? And the effective rate here, 53 out of 213 is 25% previously, right? if you think about it. Now, some people probably were taken home, I would bet you, to the extent they could. The 106 is probably reflects Hogan pretty well. I again, don't know how many people died in the past. We can find that on the June or May thing. And then you come here. These are the small homes, group homes, staffed apartments, okay? There's 1,045, not 1,060, as I said, but these numbers, by the way, this number, current census, this is state operated. This is the census of the provider operated, okay? And so there's current clients, it's a 3-to-1 ratio in staff, just to show you, and the nursing that's assigned, okay? There's current state staff cases. They don't show the deaths separately, they show them together, okay? You've got 149 recovered. So if you look, they say, oh, 149, these guys had 1,250, that's terrible. Well, no, that's 7,760. So at the height of the crisis, I run the percentages, it was 14% in the state ops with assigned nurses, with 3 staffings, and it was 16% at the provider run homes without that same, level of, and by the way, they didn't get their funds. They had to go ahead and invest in whatever. And that's part of the story today. So I'm going to share with you, let's treat people equally. Let's realize we're in the midst of a crisis. We don't, you don't have to always treat them equally if you don't want to. That doesn't happen, but at least during a crisis, let's make sure the resources are there. And right now there's 34. This is the thing that I was talking about the case. And then you can go through this and see other statistics. One of my colleagues early on said to me, oh my God, look how low it was in mental health. And, and especially early on, like this doesn't look as low as it was. It was, very low early on. And I don't know how much of that was folks are more independent, have less staff, covering duplicate sites. I don't, that'd be an interesting thing. We'll find that out, obviously, with debriefing it, So let me go back. We'll go back to the, so everybody understand this? Any questions about the charts? If you look down here too, MCB, 54 is the client census, 6 recovered, 0 deaths in the past 7 days. Mass rehab, so I'm not sure how many congregate sites to 126 people, because DDS is doing some of the residential now. Anyway, you get a feel, and it's something. If you Google, like I said, it's really easy to find. I'm surprised how easy it is to find it. Back to the PowerPoint. I got to go down a couple of slides, get back to where we were, deep dive 2. So this is what we were just talking about, play from current slide. So there's, 2 basic, in terms of the day habilitation is the second core program in the system as we think of it. Employment at day, I give you the line item 5920, 2025. Mass health day habilitation is entitlement. So it's not a matter of the appropriation, it's a matter of a supplemental budget if they spend more money. But here DDS had a $34 million cut. And that $34 million cut isn't just less than what the governor proposed in January. It's actually less than 2020, which ended on June 30th, okay? And that number would probably be, if it wasn't for COVID, what would have been billed during the year and then some. They probably wouldn't have had enough money because between 20 and 21, the day and employment services line item probably didn't grow sufficiently based on the number of people turning 22 the year before. Because that's how we look at it again. We look at, oh, what's this, day in employment? How many people are going to go day have instead of day in employment? And CBDS, as was mentioned, community-based day supports, that's the initials. And that's based on the appropriation. So, we'll basically the 2 problems, it's not just the reduction in the budget, which is a problem, it has to be restored. But DDS and Mass Health both have this other problem in that a provider cannot fully bill for their costs. And basically, when I'd done a survey, and I think I'd share this, that providers are spending anywhere from 1.5 times to over 2 times their ability to bill the state. So some will, I can't imagine after we advocate all of us that it will stay that way, but if it does, day settings will close and some agencies will close permanently. So then you have to go back to start. And that's what we were having that conversation earlier. And basically, in this case, restoring the cut and allowing them to bill as if it was January or November of last year, that should at least, it's not going to necessarily allow them to break even, but it's not going to let them go out of business. So most may be able to break even with that. The other thing, we'll talk about that in a minute. Any questions on the day, and we'll go to residential.
Yeah, Diane was wondering, what do you mean provider cannot fully bill?
Great question. And well, that's what we were having. It was a Kathy or the original discussion earlier a few minutes ago. That so they can only bill for the time people are there. And I'm trying to look to see if maybe that's another thing, another slide, not for today, another time. So imagine you're 100%, right? And out of 100% in a day of habilitation, almost 90% show up in terms of the days of the year, right? Say it's 250 days. I don't know what it is. I'm making that up. But it's probably close to 250 days a year. But now, instead of filling the place to 100%, out of which you're able to bill 89%, right? In any given year, snow days, vacations, you name it. Now you're finding you only have 35 people out of 100 going in there. So you can't even get close to billing your 89%. Now you'd say, well, that's okay. Can't they cut staff? Well, no, they might have fewer staff than they did, but they still have, unless they let go of a site and consolidate, well, that's not going to help. You need to have 6 feet all around. And the 6 feet, I've been told, actually comes down a radius of 12 feet. So now you've got that problem, and I gave you the example. I don't know if I can show the pictures here. Let's see if I have the picture. Yeah, this is a little bit over the top because there's 3 people instead of 2. But there's 2 staff to 2 people because 2 people didn't show up that day to that classroom. There's normally 2, and I asked for the picture so I could show you guys. I have another picture of a van. There's 2 people in a long van, and their staff, so that I didn't have to get releases for those individuals. I needed releases for that one. But yeah, so that's what I mean, Diane. It basically, you have more staff involved. You can't bill your full contract, but whether it's DDS or the billing for Mass Health, and that's where the problem happens. And again, it's also, I know one provider, more than one, that did their own transportation, even though they didn't have a transportation contract, because they were thinking logically, well, let me try to get at least 35%, 40%. So I'm doing the best I can. And then some people are taking turns. Some people, again, for health reasons aren't going to go, but the families, supposedly people living independently or with family, were first on the list to come in. And there were some issues with that, because if someone has a behavioral issue, you again have to deal with the whole distance, social distance piece of it. How do you manage that? So does that answer that question? Any other questions?
Leo, this is Mike Malone. Just want to make a point.
Sure.
I know you know this, but the people on the call may not. ADDP is surveying members about program potential closures of people without programs, and is submitting that information to to EHS and DDS. And the numbers are in the thousands in terms of people that may not have programs.
And by that, you mean people that just can't get in or don't want to come in, combination?
No, more that programs will need to close once the retainer payment.
Oh, okay.
Yeah.
Okay.
For example, if you have a program that usually has 60 people, but 10 people, and you can only serve maybe 20 if everybody shows up, and only 10 are coming in, you may have to close the program and just figure out how to work with landlords to eat the overhead on the building.
Mm-hmm. So what you're saying, you're anticipating a couple of months down the road here, for some a month down the road, but I know one of the people I know well who's in Southeastern Mass and has only day programs. He said to me, he doesn't know the exact date, depending on how much he keeps cutting administration and stuff like that. Will they last till, February 20th, or will they last till January 15th, but it's imminent, and then others, once you close a location, this is the irony. So here's the irony. you know, you close a location, there's two ironies. There's less people, but you need to bill the same amount, right, to stay stable financially, okay? And then the other irony is you close a location because financially, now you got more problems because of transportation and you have less space, right? So you just mess that up, right, Michael? So it doesn't really, it puts, there's 10,000 people served through DDS Employment Day. There's about 10,000 to 11,000 in day hab. Assume assume part-time attendance for 2,000 of those people, right? If people are in day habilitation and employment or day habilitation in CBDS. So say it's really, 18 to 19,000 people, right? And well, it doesn't take much for thousands of people, right, to not have a service. And again, the service is limited too, right? Because either people are going full-time and others aren't getting in, or people are going half the week, which I think is happening in most cases, and other people are going in the other half.
Another question, Leo. Diane was wondering, what do you mean? Let's see. So are more folks, that is, and better for providers in terms of staying in business? The more should people go back to program because it's better economically if people start going back? Will it make them stronger?
Well, yes, I think to the extent that's part of the problem, to the extent that's a problem that people are under, what do you call it, attended, that yes, that's one step, right? But the second step is them to be able to bill based on typical, what we call utilization or typical attendance. That's a better way to say it. Which again, if you're sitting there as a taxpayer or a family or a person with disability that's not really seeing the whole thing, you're going to say, well, hold it, why should they get paid that? Well, imagine a year from now, once COVID's over, and you had a minimum of 10 agencies totally out of business, right? Minimum of probably 30 to 50 sites closed, what do you think it'll take to restart the engines, And it's just not like turning a key, right? And then you're going to be hiring staff brand new. You think the workforce thing's tough right now. It's just going to get tougher. And that's the other problem with this. It's just hurting like all the issues, stability. So here's the infection control. This is just to explain, a little bit of why the financial adjustments are necessary. And if you look at bullet number 1, what's really frustrating during this period, and I realize the decision makers have been in crisis and this pandemic's never happened before, but we've had at least 3 different funding strategies from, decision makers during this process. Now you're running an agency. If you want to predict so you can be better for the people you serve, right? You need predictability, right? You can't think about that. You don't know what's coming in. You don't know what 2 months from now they're going to do because this arrangement's only good for 3 months. This has been one of the major problems too. So then what do agencies do? They make conservative financial decisions, right? And they go with the option that's, they're already worried about what's going to happen tomorrow, and it's like, okay, I've got to take this strategy. And then finally, not only does that put agencies at risk, but it limits personal outreach. If agencies had predictability, maybe say, you know what, let's figure out a way we can get to one person we serve who can't get in here once every week. Is there a way we could figure that out given the situation? Train some people that aren't used to seeing people individually how to do that. And then you could focus on those kinds of things. And of course, we're saying you have to allow revenue based on typical billing attendance during pre-COVID. And then, so that was tied into what we just talked about. So we won't stop there. We'll go into residential. All right. And I can't believe it's already 12:42. Wow. Okay. So after 3.5 months, a week or two ago, it was announced 5.25% funding for DDS residential providers. Now, what I mean by that is since July, providers who run residences who don't have people on a third shift, which is most of them, we're paying for that. Again, putting the money out, having people during the day, and not getting reimbursed. And so 5.25%. However, during the crisis, it averaged out to 17.5% that providers needed and received. So there's a gap of 12% for the costs and the surge. And again, this is where you go to that chart on June 10th or May Over 1,400 caught the virus during the first surge. 150 people have died, at least 115 people. And in addition, the state is holding off the rate increase from July to January 1st, okay? If you include the rate increase, which I don't want to, I did originally, this is how this thing keeps getting refined, that rate increase will be 10% on January 1st. It was supposed to be 10% on July 1st. So 10% for 6 months spread out over 12 months is 5%. So you could argue, well, Leo, you know, that's going to be 10.25%. Well, it's not, because this is, again, how cockamamie some of these financial things are done. The 5.25% is only for 6 months. 3.25% is for 12 months. So you would have 3.5% in January 1st, plus the 10%, okay? And you get to 13.25%. Think about that for a second, okay? But that 10% is really supposed to increase salaries, pay for new expenses, right? The 3.25%, that's for this problem, which is 14% off. So again, I'm not trying to confuse you, but the bottom line is it becomes, if you take the 2% for 6 months, take the 10% for 12 months, even with the rate, even if you use that rate money for what it's not supposed to be used for, you're still at 8.25%, because it's 5 plus 1 plus 3, 6. No, I'm sorry, you're at 9.25%. So that gets you to, you know, still a serious problem when you compare it to almost 18%. So this is what they're dealing with. So this is like the, you know, any questions on the residential piece. And this is what we think should happen. We think the day employment line item should be at 253.9 million. You can round it up. That's the line item number. We'll have a phone to action alerts up soon. Increase family support to 86.8 million. Address PCA approval of hours. It's the parsimonious approval of hours that exists. Allow DDS and Mass Health Employment Day Services to bill on pre-COVID utilization at 17.5% instead of what it is now through the fiscal year. That costs $106 million. And do the rate increase on time so they can also address the terrible workforce shortage that's existed, and address AFC caregiver stipends by a minimum of 12% separate from the rate review and PPE needs. So it's pretty clean. It's pretty logical based on what we just walked through. Any questions on that, even though we're on overtime?
None in the chat so far.
All right, so just in closing, the first surge was devastating. I just showed you a USA curve chart that changed in a week that shows it at the same height as we saw in the summer across the country. Our safety net is at risk given funding mechanism. Most participants are served through the private system. They don't have the 3 shifts. They don't have the nurses on staff. They have nurses, don't get me wrong. They figure that out, but it's all based on reimbursement. And the financial support should correspond with best infection control policies. We need to be together. If we're really going to be together, let's really be together. So that's, you know, basically the thing. And hope you can support us in our advocacy. But I also want to remind you, we've shifted sort of the strategy. The third Thursday will be Maura and Ellen talking about federal and state government affairs. We'll be doing a weekly update, still Leo Live. I'm going to do a new share and show you the sort of week thing. My goal is, you know, policy. That doesn't mean we won't have, if things are happening, we won't change it on a given week, but policy and understanding the service system. That's a theme for now that I think probably we could do for a bunch of weeks. Election coming up in November, so we'll cover that on right after the election, that Monday after, and maybe a little bit the Monday before, but typically that'll be Empowerment, Engagement, and Inclusion Week. Kerry will talk about resources and supporting families every 3rd week, and we'll do a recap of state, federal, and COVID on the 4th week. And as COVID keeps going, I'm sure that'll be a couple of slides each week, you know, to share with you as well.
Yeah, I just wanted to add, Leo, that we're also this fall bringing back our monthly to bi-monthly webinars, which are separate from all of this. So this Thursday, actually, we're having an adult sibling panel, which is going to be pretty exciting. And we're planning some additional ones for the winter months. So I hope you can keep an eye out for those and join us. So thanks, everyone.
Great. Thanks, everybody. Have a great week and stay safe. And let's all stay safe during the weeks coming up. Hi, Anna. How you doing? And Ann, I'll have to catch up with a few of you. All right, Kathy. And other. All right. Take care.
Thank you.
Bye-bye. Good seeing you.
Thank you. Bye-bye.
Bye-bye.